All right, so we're going to move on to principles and techniques of complex spine surgery. We're moving, we're a little bit behind, so I'm going to cruise through this. This is typically a topic you want to take your time and really, it's because a lot of the concepts are a little bit more difficult. And in the neurosurgery world, some of these concepts are still fairly new to some people. So I'm going to go through it for the sake of time pretty quick. But hopefully you can get something out of it, and then later on you can go through the slides again, just for repetition. This stuff is just a matter of repetition and doing it over and over again. Again, I'm Dr. Awuor. I'm a neurosurgeon at Ohio Health Grant Medical Center in Columbus. So, spinal deformity will range from biplanar deformity to more complex 3D deformity, like what you see in that image, where there's rotation, there's coronal deformity, there's sagittal deformity. So these things can get pretty complex. Historically, we focused on coronal deformity. That has now been kind of put to the wayside. We look now at sagittal deformity more so than anything else. Sagittal deformity, data now shows that if your lumbar pelvic parameters are off, these can lead to your health-related quality of life is going to be decreased. Spinal deformity leads to suboptimal alignment, increased energy requirements, and then you're using more energy to maintain posture and balance. Does anybody know the concept of the cone of economy? I want everybody to stand up. Stand up where you are. And we're going to see who is sagittally balanced and who's not. And I will be able to tell just by looking at you. Any patients that I have that have a deformity, they stand up, they put their feet together. Now I'm going to start looking around whose balance is a little bit off. Put your feet together. Put your feet together. Okay? And then, now you're going to move in a cone. And try to make that cone as big as possible. And that is your cone of economy. That is where you're maintaining upright posture without energy expenditure. If you're doing this, because you cannot maintain that cone of economy, then you are not sagittally balanced. So your cone of economy, this is a concept that was started by Hussein, who's a French surgeon, and he was the first to consider the pelvis critical to global alignment. The cone originates from the feet and projects upwards to find the range of motion that you can move in without significant energy expenditure and without external support. Now, the ideal spinal alignment, you're upright in that zone, and you have painless posture, and during rest and during motion. Do any of you have pain with standing in that position and doing that cone? Everyone here is balanced. This is great. This is great. No one needs spine correction here. So spinal deformity forces the body out of this cone. What happens? You start using more energy to maintain posture. You start recruiting compensatory mechanisms from knee bending to pelvic rotation to maintain the balance or to compensate for the loss of balance. Then, if assistive devices are also used, if that internal compensation is insufficient or requires too much energy, that's where you start seeing people using walkers or a cane because they cannot maintain that sagittal balance. They cannot maintain that posture without significant energy expenditure. Now, I consider every degenerative spine typically that I'm going to view as a deformity until proven otherwise. A lot of things, you look at the x-rays, you might think that, there's no deformity here, I'm just going to put some screws. I typically consider everything as a deformity until proven otherwise. What does that mean? So I'll get either a scoliosis series, or at our hospital we don't have the 36-inch cassette images, so I just get a scoliosis series on these patients that I'm going to fuse. What does this help with? You can look at the relationship of the trunk to the pelvis, and you can also look at what compensatory mechanisms, be it knee bending or pelvic tilt, that's being incorporated into these patients' deformities. So let's go over some quick definitions. In anybody that's doing spine fusions, these are things that you need to know. If you're going to put a screw in a patient, you need to know this stuff because this is becoming really the standard. So first thing, SVA. The SVA is a quick way to assess global spine alignment. I don't like the SVA because it does not account for the compensatory mechanisms, be it knee bending or pelvic rotation. Because what happens is you can control your SVA. I can control it. I can bend my knees and get a better SVA. So SVA is not my favorite thing, but if you have a good X-ray, it's helpful. It's the horizontal distance from the C7 plumb line to the posterior aspect of S1, the S1 vertebral body. So usually we want that to be around 5 centimeters. In older patients, I don't try to correct the SVA too much, as in younger patients we try and get it within 5 centimeters. Some other definitions. The lumbar lordosis is something that we need to be familiar with. It's the angle formed by the superior end plate of L1 and the inferior end plate of, the superior end plate of S1. The thoracic kyphosis, T4, and the superior end plate of T4 and the inferior end plate of T12. And SVA increases with age, and that's as a result of, as you age, your thoracic kyphosis is going to increase, your lumbar lordosis is going to decrease. Now, the normal lumbar lordosis is about 40 to 60 degrees, and like I said, this will decrease with age. The pelvic incidence. It's an angle formed by a line drawn between the center of the femoral heads and the sacral end plate, and a line that's perpendicular to the sacral end plates. This represents the sacral relationship to the acetabulum, assuming minimal motion at the SI joints. So you can see this angle right here. That is the pelvic incidence. And we call it static, but you can see that sometimes with surgery you can have some minimal changes in that pelvic incidence. The pelvic tilt. If you forget everything else I said today, remember the pelvic tilt. To me, this is probably the most important thing. Lumbar lordosis and pelvic tilt. Pelvic tilt is very important. It's the angle created by a line from the midpoint of the sacral end plate to the center of the femoral heads. That's why when you're getting X-rays for these, I can't tell you how many times I can't see the femoral heads on my X-rays. I send the patient back. I say, I need better X-rays. I need to see the femoral heads. I need to see the femur because I need to know what compensatory mechanisms are taking place. So it's the angle that's created by a line from the midpoint of the sacral end plate to the center of the femoral heads and a vertical plumb line. With age, the joints become more arthritic. You have decreased angle of motion. You have limited ability to augment your pelvic tilt. And as your pelvic tilt increases, your health-related quality of life decreases. So pelvic tilt is inversely related to your quality of life. So if your pelvic tilt is going up, your quality of life is going down. So that's why I said, to me, this is probably the most important of these parameters. And usually you want to get this less than 20, but the numbers that you see in the books are usually -5 to 30. And like I said, to me this is more reliable than SVA. And then the sacral slope is an angle that's created by a line parallel to the sacral end plate and a horizontal reference line. This leads to an equation. The pelvic incidence equals the pelvic tilt plus the sacral slope. As the pelvic tilt increases, the sacral slope decreases. So just remember that. So the spinal pelvic alignment. Why is this important? It's the single most important factor that determines outcomes in adults undergoing spinal deformity surgery. These numbers actually mean something. They're very important. If you're going to put a screw in a patient, you need to know these numbers and these parameters. So a high pelvic tilt indicates that the pelvis is there's pelvic retroversion, which is caused by an attempt to compensate for a low lumbar lordosis. remember this slide. So, two things you're going to remember are what the pelvic tilt is, and that lumbar lordosis is important, and that you want to get your pelvic tilt below 20, and your pelvic incidence minus lumbar lordosis needs to be less than 10, plus or minus 10, because those are the parameters that you're looking at to achieve. These are the things you want to achieve in surgery when you're doing a deformity case. And that's pretty much it for the spinal pelvic alignment that I'm going to go through. Now we'll go through a few cases, and we'll see whichever resident answers the most of these questions, I have a prize for you. Okay? All right. So, case number one, a 24-year-old with Down syndrome presents with progressive gait instability and hand clumsiness. The patient's caretaker reports that examining increasing falls. He's also frequently dropping things and has worse coordination with his hands. What is the spinal deformity most common in Down syndrome? Anybody?
The occipital atlantal instability.
Great. That is correct. You are on a roll. The normal atlantal dental interval in adults should be less than what? Anybody? Residents? The residents will have 5 seconds, then we'll pass it on. So for the sake of time, okay. 5 seconds is up. No one wants to. Anybody?
C.
I hear 4. Anything else?
I hear 2.
2. Anything else?
One more than Sam, right?
In children, it's 4. In adults, it's 3. Less than 3. An increase in the atlantodental interval suggests compromise of what ligament? Anybody? I hear something over here. Transverse ligament. Great. The measurement depicted in this figure is
that's the space available for the cord.
awesome. Space available for the cord. Surgical fixation for symptomatic transverse ligament laxity is what? Best answer. There's different stuff you can do, but what's the best answer? So that's actually a contraindication for an adulterated screw when you have ligamentous issue, laxity. Anybody else? Anybody else in the room want to take that? What's that? Oh, so if you do an occipital plate to C1, have you fixated the problem? No, right? You have to cross where the issue is. So, anything else? What did Dr. Patel talk about? Exactly. C. So the answer is C. You have a 64-year-old gentleman that presents with chronic back pain and low back pain. Those reports that he has worsening overall neck range of motion, that he is being slowly, progressively pitched forward. The imaging findings best describe that of what? These imaging findings best describe what?
Option D.
D, ankylosing spondylitis. Ankylosing spondylitis generally affects what in order of occurrence? Anybody? How many people say A? How many people say B? Any C's? Any D's? We have some D's. All right. On radiographs, the cervical spine in ankylosing spondylitis is characterized as what? A? Any A's? Any B's? Any C's? One C, only one C. Any D's?
A's.
Any D's? One D. All right. So these patients are typically osteopenic, but they have fusion at the joints, and the joints themselves fuse, so it decreases the load, the forces on the actual vertebral body, so they become osteopenic, though their joints are fused. So when you're doing surgeries in these patients, typically we do long constructs. That's something you really have to pay attention to when doing surgeries on patients with ankylosing spondylitis. Spine fractures and ankylosing spondylitis is generally characterized as what? A? Any B's? Any C's? And any D's? And the D's have it. The measurement characterized in the diagram is A, any B's, any C's, any D's, anybody? A? And I'll go over the SBA. This is the shin brow vertical angle. Usually you want to get this when you have these patients with chin on chest deformities. You usually want to get this number within 10 degrees for optimal outcome. And this is a patient, you see 65 degrees taken down to 60. It's not great, but usually 10 degrees is what we're looking for. All right, the osteotomy technique shown in this picture for correction of sagittal deformity is what? A? Any A's? The one A. Any B's? Any B's? Any C's? And any D's? I'm not getting a lot of votes here. But it's, which one? It's not B because look at the pedicle. The pedicle is still there. So this is what's called a Smith-Peterson or Ponty osteotomy. Okay? All right. So what's the horizontal distance from the C7 plumb line to the posterior aspect of the S1 vertebral body? Anybody?
Someone said earlier.
What is it? I'm hearing whispers. Just speak up. Anybody?
SBA.
SBA, thank you. So the SBA. So the C7 plumb line to the posterior aspect of the sacrum, we call that the SBA. And we want that number to be, what's the ideal number? Less than? No? No? 5 centimeters. Less than 5 centimeters. What is the angle formed by a line drawn between the center of the femoral heads to the sacral end plate and line drawn perpendicular to the sacral sacral end plate? What is this defining? Huh? Pelvic incidence. Pelvic incidence. Is this static or dynamic? No? Static. The dynamic one that you use to compensate is pelvic tilt. So, question. A 40-year-old presents with severe back pain and multiple lumbar degenerative discs and has a lumbar lordosis of 30 degrees, a pelvic incidence of 40 degrees, and a pelvic incidence of 40 and a pelvic tilt of 40. Is this patient in sagittal balance, and why or why not? Just look at these numbers. What's that? Can we have a mic?
imbalance. You see, look at the equation of pelvic incidence equal.
If I take the pelvic incidence, which is 40, and I minus the lower lordosis, which is 30, the number comes to 10. Is the patient balanced or not balanced? Huh?
Imbalance.
Imbalance? Why? I didn't say that. You want to get the number to less than 10, plus or minus 10.
Yes, 30 degrees.
What's that? Here's what? Anybody?
40 minus 30 is 10. It's really bad.
So using balance. Balance? Anybody else? Okay, so I'm going to say that this patient is not balanced. Why?
What is that? That makes balance and measure. Pelvic tilt.
Pelvic tilt. You've got to look at the pelvic tilt. You've got what's happening. The patient's faking us out because they're retroverting their pelvis. Okay? They're compensating. So if you fix this patient and say, oh, this patient's well aligned, I'm just going to fix this right here. You fix them in that pelvic tilt, which you want that number to be less than 20. So don't be faked out by the pelvic incidence minus the lumbar lordosis. That is just one thing you have to look at. The other thing you have to look at is, are they compensating to get those beautiful numbers? So the pelvic tilt then tells you that actually this patient has a retroverted pelvis. The pelvic tilt is high. They are compensating for that, trying to reduce the energy expenditure by retroverting their pelvis. Okay? Pelvic incidence equals sacral slope plus. Anybody?
PT.
Pelvic tilt. What are the spinal pelvic parameter goals of surgery that we talked about? The take home for this talk. What numbers are you trying to achieve? As far as if you're measuring these numbers, what are you trying to achieve?
Trying to achieve sagittal balance.
Sagittal balance, and you're going to be in sagittal balance with what numbers? So I'll give you a hint. One thing that I like,
Pelvic tilt.
pelvic tilt, you want the number to be
Less than 20.
less than 20. Then there's something else that we talked about. I told you can't look at it independently. You have to combine it with the pelvic tilt. What is that?
Small.
No. The mismatch. The pelvic incidence minus
Lumbar lordosis.
minus the lumbar lordosis, and you want the number to be
Less than 10.
plus or minus 10. Thank you.